So we've kind of said this already, that there are two real types of injury. There's that high-speed injury, which is those common things are common. And again, as Nicole said, the main thing's the main thing. So we know that biceps femoris is the most common injury, but we've also got this excessive lengthening, which we're not really going to cover in this presentation. We know that with proximal injuries, in sprinters certainly, if the proximal tendon is injured, then it takes significantly longer to rehab, and there's quite often a concomitant injury. So you need to MRI or scan the whole thigh in order to make sure that you haven't got two injuries coexisting at the same time. And that's from Carl's work. And we see that hit clearly here, that the proximal tendons are significantly longer to heal. So your timelines are going to change, and that will certainly be influenced by that sprint hurdler that we've got, that we presented at the beginning. Craig's talked about this at length, and so did Carlos. Central tendons or intramuscular tendon is critical, and we see that the timeline for healing is almost 3 times that within the biceps femoris group if that gets injured. And same thing with the semitendinosus sort of group as well. So pretty significant if the central tendon's there, and that's where the imaging is critical to differentiate that out. So that moves me slightly closer towards Natalia's model, where we've got this typical versus atypical injury. So I think if you've got a common injury, you can treat it in a structured way and have that pattern recognition around that. And we see that proximal biceps femoris injuries in terminal swing phase are common, distal medial hamstrings in stance phase are common, proximal semimembranosis in stance phase on rapid stretch is common. And that 80% of these injuries occur in biceps fem and 66% at speed from excellent work. The atypical ones are when you get that distal biceps femoris injury, and that worries me, or that proximal medial hamstring injury in swing phase, that worries me, or an overstretch injury to the lateral hamstring complex, again, that worries me. And that's when you take a step back and you start to proceed with a lot more caution than what we're going to show you later. So we end up with this pathology into mechanism into classification, where high-speed running really becomes pretty critical, and we'll show that in the risk indices in a second. The mechanism is swing versus stance and overstretch. And the classification, there really isn't a consensus, but at the moment, the most common or most intuitive tends to be the BAMIC. But there is also limitations within that classification system at the moment that we need to then talk around and add value to. And I know Noel Pollock is looking at that at the moment. So that then raises the question here within the injury continuum. And what we see is if we argue that there's just 3 muscles and not the 5 I argued earlier, we've got potentially 3 mechanisms. We've got potentially 4 grades with 6 different locations and 3 different sizes in terms of its influences. So when you do the maths and all of that, it actually tells you there are 648 different variations of a hamstring injury. So to just look at strength, to just look at certain exercises, to just look at paradigms or protocols probably is doing a big disservice. But I think you need to look at that variance, and there'll be uncommon injuries, and then there'll be typical common injuries, which leads into Natalia's work of that complex system analysis. Other variables you need to consider is that typical atypical injury, the central or free tendon, proximal versus distal free tendons, transverse versus longitudinal injuries, the architecture of the muscle, the synergy, the technique, positional demands, and any previous injury or scar tissue, as Brian rightly pointed out as well. So that tends to lead us on into this risk sort of model, and the guys have presented this already, so I'm not going to spend too much time, but you've got age and previous injury as being key, but they're univariate analysis. We've got a lack of consistency in the strength data. We know that eccentric is important, but it's at slow speed at 60 degrees a second. If we're talking about a sprinter or a fast team sport athlete moving at between 7 and 9 meters a second, or up to 32, 34 kph, the knee's moving at 760 odd degrees a second versus a 60-second eccentric isokinetic device. Again, we're not looking at the same parameters within what we're analyzing. So we need to again understand the architectural components, but that becomes a physical quality, which Fionn rightly spoke about. I think one of the risks that, again, people have looked at different muscles, different injuries, but those muscles, low back pain, a calf injury, an ankle injury, don't cause a hamstring problem directly. But what happens is they alter kinematics and they alter your movement. And as Brian rightly showed with that dislocated shoulder, that altered movement patterns. So we need to lump all of that together and say kinematics, and that really hasn't been looked at in enough detail yet in terms of its exposure risk to hamstring injuries. And so when we're looking at complex systems analysis a la Natalia, then we're looking at strength, sprinting speed and exposure, increasing that risk. So we need to move to this paradigmal shift, and Natalia presented this earlier in terms of Mendes-Gutierrez modeling earlier in 2012, and then we've modified Natalia's work here into this 2016 model where we've increased the hamstring elements down the bottom and adapted that model itself. So that leads me into just taking a bit more of a bias here in terms of the data and sort of saying, well, high-speed running really it's the mechanism of injury, it's the disease, so it's the biggest risk factor. So we might say, well, previous injury causes that, but that's 30-odd% previous injury causes a re-injury rate when you look at it. And even when you looked at Nicole's risk indices, it was 37% or something like that, I think he said, was the risk factor around disease of a previous injury and or problems that are occurring. Whereas actually, if you run fast, it's 66 to 86% increased risk. So maybe that's the biggest risk. But also maybe, as Brian rightly pointed out, giving an appropriate dose of high-speed running under your Tim Gabbett model is also the cure, the prescription, the vaccine, whichever way you want to talk about it. So when we put all of that together and understanding running, this is quite a busy slide, but hopefully I'll walk your way through it. What we see is sprinting can be defined as 3.2 to 3.9 meters per second, which isn't quick, right? It's about 12 to 14 kilometers an hour on a treadmill. It's got a double float phase, but only 36% is in stance. And as you move to elite sprinting, it's only 22%, so less than a quarter. And that up to 7 meters a second, the key determinant is your vertical ground reaction force, thus giving you stride length. Now that comes from your ankle foot complex and your plantar flexors. It comes from your arm drive. It comes from your center of mass being forward on your base of support, and it comes from your vasty. So if I want to run up to 24 kilometers an hour, i.e. 7 meters a second, it's about my calf, my quad, and my position of my trunk. It's got very little to do with my hamstring complex. Now, 24 kilometers an hour is shifting for most of us. In elite sport, it's not, but for most of us, that's really shifting. Now, as we move to elite and we get over 7 meters a second, the hip takes over. And the synergistic function from flexion to extension is really the critical component here. All right, so what we see is that movement now towards the hamstrings as that knee extensor. The hamstrings, along with adductor magnus, producing the hip extension moment arm. And adductor magnus there producing the moment arm. And then the contralateral hip flexors, as Brian pointed out, being critical to swinging the leg forward. So we start to change the emphasis to this hip dominant pattern at greater than 7 meters. So it is possible to get athletes back running early without necessarily influencing or overloading the hamstring. Now, this is a slide here where we've got 4 different athletes, all that move at 9 to 9.5 meters a second. So you've got Alison Felix up here, 400-meter world record holder, ex-world record holder, and champion. And what you see here, not big hip flexion moment arm, not a big eccentric load on the hamstring, quite a rhythmic, but a big stride length. So huge sort of vertical forces. Shelly-Ann Fraser-Price here, world champion, 10.71 for the 100 meters last year in Doha. Again, but now big hip drive. So big vertical force, big hip drive coming in to run at 9 meters a second. If we move down to Gareth Bale, who in Europe has been recorded as the second fastest footballer at over 9 meters a second, there's no vertical force. It's all cadence. It's all frequency to get to that speed. And then Tyreek Hill, who's one of the fastest guys in the NFL, again, it's all quad and calf drive to get to that frequency. So if everyone runs differently, if the goal of sprinting varies between athlete and sport, then maybe we shouldn't be debating the specificity of exercise for hamstring strength and what we should be doing. We should be looking at how we influence running and running mechanics in the individual to get them back as quickly as possible. So if we now go back to the cases in the last couple of minutes and apply that evidence. This is the sprint hurdler that you saw at the beginning. This is the end of his race 8 days later after sustaining that grade 2. Now, as Craig rightly pointed out, some people can come back off a grade 2. We were just lucky. He didn't even come last. He came 5th in his heat. His PB is 13.2. He ran 13.7. It was the Euro champs, and then we did that over 8 days. We then took him out after those 8 days, and we rehabbed him properly for a good 4 to 6 weeks. He then went on for the next 3 years with multiple gold medals that you can see there, and without sustaining another hamstring injury. So what were key things we did? Well, the think tank will tell you that from John Orchard's work that was published in 2008, that this is what you should do: ice and compress, early mobilization, motion, massage, MRI, etc. We went a slightly different tact. We took him off feet and used crutches for 48 hours because we just wanted all the stress to be reduced. And our argument was we wanted a good tissue healing aspect to that. And we thought we'd just get better scar tissue formation. But the reality is there's an increased body of evidence that's now suggesting that if you offload the tissue, you don't get scar tissue, you get better myofibril elements. We strapped and compressed, we did ice through the night. There was little to no soft tissue work, and he had some injections just to offload some of the pain around the tissue using Traumeel and corticosteroid through an epidural. We started pull work at 24 hours, protected length tension loading at 24 hours, and running drills, and he raced at 144 hours. So what did that kind of look like? Well, we used different forms of taping, from kinesio tape on the left to control his range, to dynamic tape on the right, on the lateral hamstring to then give him an elastic component. Neuromuscular stim, as Paul's rightly pointed out, to just maximize that motor unit recruitment, which has been advocated in the research. We did protected length tension loading. It's a different athlete, but same principle. And we got him doing backward cycling, again, where that load on the hamstring is not in an eccentric position, but he's having to work his trunk there, and that's a much slimmer version of me than now. We did sort of lateral force transmission work, where we did some lateral movements and some, again, protected length tension movements across the hamstring complex here. And the key really is that you get this lateral force transmission, which then influences the tendon and influences the viscoelastic property of the tissue as we work our way through different elements and different loading structures. We also made sure that we loaded as we go. So hip flexor loading, abdominal loading, adductor loading, all in synergistic patterns. When we go back to this athlete here that we showed you earlier coming out the blocks, and just to recap, she's then generating this high cadence sort of movement with no stride length, no vertical force. And that's pretty critical. That was the injury pattern. That's what you saw from before. So when we look at prevention, Nicole spoke about this, then we've got to think about all those different strength components along with high speed running. There's been lots of talk around, right, well, let's do eccentric strength and let's have a strength protocol. And this is Nicole's brilliant work. But it also begs some questions as to what strong really is and where do we want to go. So this is one of our strongest athletes, who's actually an Olympic rower, doing an eccentric single leg hamstring curl. And he's been able to do that with 200 kilos on one leg, which equates to 2,000 newtons through one leg compared to 300 to 500 newtons that gets produced possibly on a Nord board, etc., or maybe even up to 600-800 newtons. When we do the inverse dynamics, it actually tells us that's 1,200 newtons across his hamstring complex. So that's a significant amount of force going through that tissue. I've seen lots of people present graphs like this where we talk about force velocity curves, and we can produce max force at one end and max velocity at the other. But that research, just to highlight, is based upon a single sarcomere. What we've got to look at is multi-joint movement, and how does that occur when you're producing speed. So running fast is both a high force and a high velocity movement, but the muscles are all changing their demands as they go through. And what we see is the eccentric component here on the left is really influenced by the passive nature of the tissue itself. So what did we do with her? Well, we may look at eccentric control through a Nordic, but that's not always the answer. As you can see with this girl really clearly, she's able to come back up, do a Nordic beautifully. But when you ask her to do a high-speed coordinated movement across the lumbar-pelvic complex like this, watch her left leg. Again, she can't offload the pelvic control from the hamstring complex. And then we might be adding in high-speed velocity movements like this, which again, while it's high velocity, It's also influencing the tension and the non-contractile tissue, because we're not taking the muscle to that maximum force component. So you get a much bigger influence on the series elastic component as you load that tissue in that way. Physical profile on that female sprinter, we've used Kangatech, and this is how we've profiled. So we've looked at torque ratios across left to right limb, and what you see here is the green is world-class, the yellow is well within a high percentile of excellent, the red is concerning, and then the grey in the adductor complex is really concerning. So what we see is her hamstring complex is brilliant. It's at 95 to 103% capacity. At the lowest, it's at 83% capacity. But her adductors and the other synergists in the running arc are significantly below where they need to be. So that's what we need to do, and the graph then just depicts that really clearly in terms of where we're trying to go. So we worked a lot on her in terms of her vertical force and doing isometric calf work and isometric quad work, which Fion's already shown you. We worked a lot on her adductors, and the adductors are some of the worst named muscle groups because they're extensors as well as flexors. And Fion's again spoken about that earlier. And then that offloads your hamstring complex as well when looking at adductor magnus that we mentioned earlier. We did loaded step-ups to get that vertical force, and loaded step-ups, as you see on the right from Figures' work, has an increased capacity to offload tissue stress in running. And therefore the ability to repeatedly do that and generate that vertical force becomes critical. And then we looked at specificity of hamstring loading. So whether that's overload through tension movements and going into overstride lunges. On the inside there, that's an adductor magnus being loaded in a standing hamstring curl with BFR. And we used Jordan Mendeguchia's work here, where we looked at leg curl and lunges, where we're looking at adductor magnus loading versus biceps loading to then influence the leg curl with adductor magnus to support the hamstring, and then the lunge to load the biceps femoris. So if we go back to that individual, this is her when you saw a sprint. That was the data. What I've done here is I've frozen a year later, and this is 6 months worth of intervention. And what you see on your left is that initial stride pattern coming out the blocks, poor trunk angle, poor arm drive, poor hip flexion and stride length. Whereas on the right, 1 year later, February to February, after 6 months worth of intervention in trying to influence running mechanics rather than just hamstrings, where you see much bigger stride length, much better arm drive, much better trunk position, again, able to generate much bigger force. And so far, we've had little to no niggles, in fact, no niggles in soft tissue, anywhere within the soft tissue complex at all. We've just had a very minor sort of sprain to the spring ligament and subtalar joint from running outside in adverse conditions as we get in England, as it's not as nice as in Australia. So the premise behind that is that we can influence running, we can then offload the tissue and offload the injury mechanism more significantly. And I think the key for me is then to balance between these physical qualities versus the mechanical components of running and the biomechanics or kinematics of running. That's pretty much a whirlwind tour of hamstring injuries in a case study framework. Hopefully you've enjoyed that, and hopefully that's got you guys to think a little bit more about how you might approach hamstring injuries in the future. Thank you very much for your attention.
Thank you, James. I think we can all agree that is world class right there. And again, we really appreciate your time. We know you're a busy man. So again, for myself, and I'm sure all the attendees and Nick, we really appreciate what you've done and be able to present to us. So I'll just